Hello friends, today our topic of discussion is the gestational diabetes during pregnancy, effect of the gestational diabetes on the fetus and the mother, how to control and treat the GDM for the good pregnancy outcome. Before starting our topic, my dear all friends, request you to subscribe my YouTube channel name is RM World of Medical Education because I need your love and support. Let's start our topic, which is the gestational diabetes during the pregnancy. What is the gestational diabetes? Gestational diabetes mellitus is defined as impaired carbohydrate tolerance resulting in hyperglycemia which first developed or diagnosed during the pregnancy. Today we will discuss incidence of the different types of the diabetes mellitus during the pregnancy, risk factors to develop the GDM, pathophysiology, effects of the GDM on the maternal risk and the fetal risk, diagnosis of GDM, monitoring during pregnancy or the antenatal care, how to give the insulin, mode of delivery, time of delivery, postnatal care, and at last we will discuss about the contraception. Incidence of the GDM. Hispanic, African, American and Asian populations having the incidence of 5 to 10% of the GDM. Caucasian women 1.5 to 2%. Native Americans 15%. Diabetes mellitus in the pregnancy. The incidence rate of diabetes mellitus is 3 to 10% of all the pregnancies. Person having a type 1 diabetes mellitus having a risk of 5% to develop the GDM in the pregnancy, type 2 diabetes in 90% cases, and the monogenetic diabetes 2%, mitochondrial diabetes mellitus 1%, secondary diabetes mellitus 2%, and gestational diabetes mellitus around 6 to 9%. The risk factors for the GDM. Obesity. The body mass index when more than 30 kg per meter square, previous macrosomic infant, or the weight of baby more than 4.5 kg, previous gestational diabetes, first degree relatives with the diabetes, ethnic origin of South Asia, Black Caribbean, Middle Eastern, and the women having a PCOS or polycystic ovarian syndrome, multiple gestation. What is the pathophysiology? Maternal hyperglycemia leads to the fetal hyperglycemia, and ultimately this fetal hyperglycemia leads to the fetal hyperinsulinemia, and once the hyperinsulinemia occur, it causes increased production of erythropoietin causes the polycythemia, increased production of lactic acid which causes the sudden death because the lactic acid increase in amount leads to the lactic acidosis, increased fat deposition which causes macrosomia which increase the risk of the shoulder dystocia, decreased lung surfactant cause respiratory distress syndrome. The maternal risk: hypoglycemia, women can develop the diabetic ketoacidosis, retinopathy, nephropathy, hypertension, atherosclerosis, neuropathy, and the risk of infection also increase like the UTI and the pyelonephritis or candidiasis are the most common infections. Postpartum endometritis wound and infections also noted. What are the fetal risk? The most important and the dangerous risk is the congenital fetal anomalies including the neural tube defects, cardiac defects, skeletal defects, and the specific anomaly is known as the caudal regression, while the most common anomalies are the cardiac diseases, gastrointestinal defects, early pregnancy loss, preterm labor, shoulder dystocia, macrosomia, intrauterine growth restriction also known as the IUGR, polyhydramnios, perinatal death, management. In the management, first how we diagnose the GDM. Diagnosis of the GDM can be done by the given the OGTT at 24 to 28 weeks of a gestation according to the NICE guideline. The readings of the fasting plasma glucose of 5.6 millimole per liter or above and 2-hour plasma glucose of 7.8 millimole per liter or above after 75 gram of glucose or the OGTT test confirm the women having a GDM. Once the GDM is diagnosed, the targeted sugar levels during the pregnancy means the sugar level should be maintained. Fasting should be maintained 5.3 millimole per liter or less than 100 milligrams. 1 hour 7.8 millimole per liter or less than 140 milligram. 2 or 6.4 millimole per liter or less than 115 milligram. Now the antenatal care. The GDM women should monitor in the pregnancy. Start from the first trimester. Early dating scan. The women should be prescribed the folic acid 4 to 5 milligram for the initial 12 weeks. Anomaly scan should be done at 18 to 20 weeks. Growth monitoring start from 28 weeks. First 2 weekly till 32 weeks. Then weekly or 2 weekly depend on the scenario. Give the kick count chart to the women. On examination, check for the symphysofungal to exclude the polyhydramnios or the IUGR. CTG start after 32 weeks. Biophysical profile after 38 weeks. Look for recurrent infections, retinal or the renal assessment. Blood sugar charts. If the GDM is uncontrolled, then total do the 7 readings, 6 readings pre and post meal and 1 midnight level. Once the control, do 1 fasting and 1 any post meal. The time of the delivery in the case of the GDM. If everything is normal, then deliver between 38 to 40 weeks. But if the suggestive history of the bed obstetrical history, significant past ops history, deliver up to 38 weeks. What will be the mode of delivery? The mode of delivery decide on the severity, obstetrical history, current history of any comorbid, weight of baby and the patient wish. Medicines for diabetes. First, keep the patient on the diet and exercise. Recheck sugar levels after 1 week. If not controlled, then start some sort of medicine. The hypoglycemic agent known as the metformin, it is safe during the pregnancy. If the sugar levels are between 140 to 200 milligram, then we can start metformin along with the diet and exercise. If sugar levels are more than 250 milligram, then no indication for the metformin, just start directly the insulin. Dose of the metformin 250 milligram up to 2 gram daily we can use, depend on the sugar levels, either in once a day BID or the TID dose. Insulin. No hard and fast rule of dosing of insulin. Start 6 units per day 3 times a day, or in early pregnancy start from 0.5 units per kilogram weight of patient, or in the late pregnancy we can start from the 1 unit per kilogram weight of the patient. Monitoring during labor. A vaginal delivery plan targets sugar levels between 4 to 7 millimole per liter. When patient in labor, keep her on only the plain liquid diet and monitor the sugar levels 1 hourly. Start neutralizing drip. If the sugar levels increase, then give 1 unit of insulin per 10 mg of a sugar level subcutaneously. During the seizure, we will monitor the sugar levels in every half hourly and the same neutralizing drip if the patient is NPO is started. After the delivery, what should be the postpartum care in the GDM patient? Risk of postpartum hemorrhage is more in diabetics, so do active management of third stage of labor. Give prophylactic antibiotics because risk of infection is high. Start early breastfeeding. After delivery, hold insulin, check blood sugar levels. Now the contraception. All the women should receive the postnatal advice regarding the contraception and planning their next pregnancy. Selection of contraception depends on the obstetrical history and patient's wish. According to the McWheel, safe options for diabetic patients are copper IUCD or the levonorgestrel intrauterine system, also known as the Marina. Thanks for watching. Remember to leave a like and subscribe my channel named RM World of Medical Education. Thank you. Have a nice day.